right, can you hear me now? I was saying that they may have the booze next door, but we've got the music and dancing here, so we'll definitely fit in the dancing toward the end. I'm Tom Inge. It's great to be here, great honor to be moderating this session and presenting as well, and having three co-moderators and speakers here. Torsten Olbers, who needs no introduction, Justin Ryder, who's also from Chicago, and David Sarwer, David Sarwer, who sadly couldn't be here because of a family health issue, but actually sent a video, and he'll be talking about psychological aspects of treatment of adolescents. Without further ado, I will go ahead and get us kicked off, and if I could have my slides up there on the monitor here, but on the screen. Okay, so in front of you, you see on the left-hand side a lovely shot of my now hometown, Chicago, with a lake and beautiful buildings, and then this on the right-hand side is our 22-story children's hospital, Lurie Children's Hospital. My disclosures are here. I have no conflicts of interest relevant to this presentation. But I will get right into it and talk to you a little bit about the difference between how we describe pediatric obesity and how we describe adult obesity. It's not a big difference. But also then compare adult bariatric outcomes to pediatric bariatric outcomes from some work that I've led over the last 17, 18 years now called the Teen-LABS study. I'll also share some of the longest term outcomes from this study that really looks at sleeve gastrectomy and gastric bypass in teenagers. And we have actually 15-year results at this point. And then I'll also talk about an interesting new phase of the study and one of the ancillary studies to Teen-LABS that is looking at really the toxicology of obesity and response, bariatric response. So first, the BMI percentiles. We, in peds, because the kids are still growing in height, don't go strictly by BMI. They're also growing in other ways in terms of body composition and so forth. So we set the BMI of the 95th percentile as the definition of obesity. And as you can see, and you see on the right-hand side, the correlation to adult levels of obesity, class 2, class 3, class 4, and class 5. So this is really just informational only. The data that we're collecting is not really usually pegged to these, but it's more describing the patients that come to us. And then when we see them, nowadays in the electronic medical record, this is all done for us. They have their BMI percentiles that are tracked in the medical record. And as you can see in this graph, let's see, even as young as 9 years of age, we have BMIs that are sufficiently high to qualify for severe obesity or class 4 and 5 obesity. And this data was just published last month in JAMA Open, and it really gives us current prevalence data about pediatric obesity in the U.S. In 2 to 18-year-olds. And what you can see immediately is that we have obesity prevalence, class 1 that is, and above, is at about 20% and rising. Upwards of 22% prevalence now. But the age groups that we see here represented, again, are pretty broad. What we see down here is the class, higher classes, 4 and 5 obesity, and you see there again, over the last 15 years, from 2008 to 2023, a continued gradual rise in this prevalence from about 0.3 to 1.2%. And then if you break that down by age groups, it's by and large the older teenagers that are forming the largest subgroup of those with severe obesity in the United States. So what are the selection criteria for bariatric surgery? It's generally class 2 and 3 or higher obesity. What we find in the United States is that it's type 2 diabetes primarily that would drive a decision for surgery in class 2. Most of the insurance companies have not yet adopted the broader thinking about other comorbidities being indications for surgery with class 2. And then at class 3, 4, or 5, a comorbidity is not required, but is usually present. So one of the centerpiece hypotheses for the Teen-LABS study, Teen-LABS stands for Teen Longitudinal Assessment of Bariatric Surgery, as you see here, was to compare, the centerpiece hypothesis was to ask, is early intervention better than later intervention in adulthood with surgery? And so what we did is we collaborated with an adult longitudinal study of bariatric surgery with a mean age in the 40s, typical adult study. And both of these were multi-center studies. But we enrolled the teenagers in the Teen-LABS study and really just did a secondary analysis from the adult data for patients that were similarly obese as teenagers themselves. And that was a key criteria that we wanted is to have their pound years be greater than our patients. And so we had 161 in Teen-LABS and nearly 400 in adult labs. And what they all had undergone was gastric bypass. The adult labs group didn't have any patients with sleeve gastrectomy. What we saw is that they had the same BMI outcomes after 5 years. They all lost similar weight on average at about 26 to 29%, but not statistically distinguishable. What we did notice, though, is that our hypothesis was supported when it came to remission of type 2 diabetes, with the teenagers maintaining a remission at 86%, and the adults maintaining only half of them maintaining their remission of type 2 diabetes. Furthermore, when we looked at hypertension, we found a similar story with almost 70% of the teenagers maintaining their remission of hypertension and only 41% of the adults. So we saw very different health outcomes. I would say that we answered our question from a health perspective in a very positive way. We also noted adverse events, including intra-abdominal operations and deaths, and the frequency of demise was similar between the two groups. The prevalence of the rate 2 per 500 person years in the adolescents and 2.26 in the adults. The reasons for this are shown here and are not unexpected. They were not related to surgery in the teenage group, but there were 3 perioperative deaths in the adult group. We did see more intra-abdominal operations over the ensuing 5 years, approximately twice as many, to be exact, 19 versus 10 rate per 500 person years. The next question, though, I want to address with you all is, can teens be studied long-term? Many studies that have sought to track teenagers through adolescence and into adulthood have realized that that's a real problem. When kids leave the nest, when kids get jobs, go to school, get lives of their own, it's hard to keep them engaged with longitudinal research. But we wanted to know, is the weight loss durable, and were the health improvements durable? So with the variety of tactics, which we've written down and can share, we were able to achieve a respectable 88% completion rate of visits out to 10 years, and even 95% of those that were eligible for a 15-year visit during our study, open window of the study, actually came back. So the 10-year outcomes are shown here with the sleeve gastrectomy patients and the gastric bypass patients behaving essentially identically, again, not statistically distinguishable. Our band story, we had about 15 patients that had a band who did remarkably worse than this that we've published as well. But the gastric bypass and sleeve cohort also had indistinguishable comorbidity outcomes. They were the same, and so we lumped them all together in this model that's shown here, which shows, again, type 2 diabetes, peak remission at about 3 to 6 years, and then a little bit of relapse in some of the patients out to 10 years, where we saw type 2 diabetes, hypertension, and dyslipidemia remission still right about 55%. So you might say, well, you're worried a little bit about the loss of that remission or the relapse, but I will hasten to remind everyone that in the published literature and the larger trials of adults undergoing surgery for type 2 diabetes, what we see in those longer-term studies at 12 years, 15 years, is that the remission rates are really quite modest in the teens or close to 20 for remission of type 2 diabetes. So I think that this data also, too, speaks to our underlying hypothesis, which is we need to act earlier if we're to see the best impact of the surgery for disease remission. People always ask about long-term nutritional problems, and so we were very careful to collect a lot of data and blood measurements of micronutrients in particular, and we were fortunate to work with some very good bone health scientists as well. And what you see here is a 10-year analysis, which is currently submitted for publication, was presented at the Obesity Society last year, showing that the biggest signal, and this is pre-baseline and then post at 10 years, the biggest signal for an abnormality is low ferritin levels. So as indicative of difficulty with iron metabolism or iron deficiency. High transferrin, again, seen in these patients at 34% and 13% for bypass and sleeve, respectively. And also a signal of potentially metabolic bone disease to come with an elevated PTH level in appreciable numbers in both groups as well, and low vitamin D levels that are similar between the two groups. Furthermore, vitamin B12 was not seen, problems with vitamin B12 were not seen in this measured study. There were no patients essentially with abnormalities there. This is, again, an era where we're giving parenteral B12 every 6 months to a year in our patients, and low folate levels were very small. I've been accused of leading young women to then have spinal tube defects in their fetuses because of presumed malnutrition and folate malnutrition, and it doesn't exist, at least from the standpoint of measuring their own folate levels, and we're not seeing myelomeningocele or other neural defects in progeny from our young women. But if you look at the prevalence of multiple deficiencies and just grouping them under this category of multiple deficiencies and look at 3 or more deficiencies, you do see at 10 years that the gastric bypass, patients that underwent gastric bypass have perhaps twice as many in that category of multiple deficiencies. So again, comparing the single deficiencies is an objective way to do it, but then lumping them all together into a composite multiple deficiency category, you are able to tease out maybe just a little bit a greater sense of safety for the sleeve gastrectomy. Also, when you look at hemoglobin-defined anemia by surgical procedure and visit, you do see a difference for most of the 10 years with fewer patients in the sleeve gastrectomy group having anemia, and then by the time of 10 years, they're perhaps getting a little bit closer. But again, a signal for perhaps greater safety for the teenagers who underwent a sleeve gastrectomy. I have no doubt that there's virtually no difference in their compliance with the supplement adherence, but I'm not showing supplement adherence data today. In terms of the bone mineral density, I'll show some DEXA data here, not ours, but Madhu Misra at MGH and now UNC looked prospectively at 2 years, baseline to 2 years with DEXA scans, and did find a signal compared to normal controls, weight-matched controls at the femoral neck and total hip for reduction in bone density. When we then looked at 9 years at the gastric bypass and sleeve gastrectomy group from Teen-LABS and with DEXA scans with a weight-similar control, and I'm sorry it doesn't project well, but it's published, you can see also that there may be a hint of a greater deficiency or reduction in bone mineral density for the gastric bypass compared to the sleeve, and this is the control group, again, age-matched and weight-matched at the postoperative 9-year time point. At the total hip, however, that's the spine, lumbar spine, total hip, there was greater bone density in the controls and lower in the gastric bypass and the sleeve gastrectomy. Again, gastric bypass being somewhat lower. I think I'll just push through this one and get to the 15 years so I'm not over time. Of course, I'm the moderator, so I don't know, does that mean that I have to take myself off the stage if I go over time? I don't know. At 15 years, we had 40 patients that were eligible for a follow-up visit. 38% of them came in for a follow-up visit. And this was a 10-year study, but because of the long enrollment period, that is, we had some that came in for 15 years as well. And you see this fairly monotonous change, if any change, out to 15 years, between 10 and 15 years. So again, about 20% weight loss at 10 and 15 years. Actually, here we have some actual data. So the baseline BMI in this group was 56, which was similar to the baseline group in all of our cohort. And the 15-year BMI was 44, which was a mean reduction of 20%. So that remains statistically significant. I didn't show you spaghetti plots anywhere else, but here you see this rich variability in the results, with some patients losing as much as 50% and maintaining it, or 60% and then maintaining 50%, whereas some patients actually gained weight and remained very, very heavy. So this is, again, the kind of data that lends itself to asking the question, what is the variability all about? But just back to the results for a minute from this 15-year analysis, what we did see is that they were, in general, very healthy from the standpoint of the biomarkers around dyslipidemia, diabetes medications, and hypertension medications, all shown here, remarkably reduced still at 15 years. So that one final nagging question, though, related to this variability in the BMI outcomes. What causes it? Why are some patients maintaining 50% weight loss, whereas some are regaining and remaining very high in their BMIs? Is it their diet? Is it their microbiome, physical activity? All of these things that are discussed and scientifically investigated. And I don't have data on all of them, but I do have some remarkable data that I think is very intriguing from the environment. So what is the environment? The environment, of course, is where we can go out and play and have fun and run, but it's also a place where there's a lot of toxins. And so forever chemicals are all over the world. They're in a lot of industrial manufacturing. They're in consumer products, including the nonstick coatings on our pans in the kitchen, including the food packaging for ultra-processed foods that we also adore. There are about 10,000 of them that are resistant to degradation. They're detected in the blood of almost all of us. In fact, they're per- and polyfluoroalkyl substances, and they disrupt metabolism. They probably cause diabetes, and they probably cause obesity. And the question is really, what else do they do? Do they somehow sabotage our weight loss attempts? This is just a graph of the water contamination in the United States with 9,000 of these types of chemicals, and again, cause a lot of problems. I know my time is over, so I'm just going to get to the punchline here. We actually collaborated with a group at USC who took blood samples that we had banked and took some even fat and liver samples that we had banked, and they measured with mass spec the presence of these forever chemicals in the blood over time. And the punchline here is that they were able to describe a real effect of these chemicals in the blood that actually correlated to their concentration in the blood. And so I was, again, very impressed to see that with many of these chemicals, they saw the obligatory loss of weight in the first year, but then gradations, depending on the concentration of the forever chemical in their serum, gradations of impairment of maintenance of weight loss, in other words, weight regain. And just again, quickly, some of them regaining 16 kilos over the 4 years between year 1 and 5, some gaining as much as 21 kilos. So this could be a hidden factor in not just the teenagers, but in adults, and I don't think it's been reported before. So it's something to really consider. So in summary, adolescents are becoming increasingly severely obese. Bariatric surgery is effective, bypass and sleeve gastrectomy, but I think it's underutilized. And early intervention seems to be better than waiting until adulthood. We've seen pretty modest nutritional abnormalities or deficiencies at 10 years. And the variability in weight loss is complex. I think that we should take this as another sign. Don't blame your patient because we might not know everything about what's driving that weight regain. So with that, we were instructed to put the reminder slide in, and I think we'll take questions at the end. Yes, we have an agreement with that. So hold your questions. Thank you for your time. So Torsten is up, and will talk to us about the AMOS studies. Thank you.
Thank you, Tom. Thank you, Justin, and thank you for coming late in the evening. Let's see if we can have the slides. It's here. Should I maybe put them up? Is that what? Yeah. Okay. So I'm gonna, there they are. Good. I'm gonna talk about the Swedish experience from 2 studies, AMOS studies. AMOS is the first. It's like Home Alone, isn't it? What is this movie, Home Alone? That is, you don't have AMOS 1, but you have AMOS, and then you have AMOS 2. Those are my disclosures, all reimbursement to my institution. And when talking about metabolic bariatric surgery in adolescents, I think that this is the, either you are for or you seem to be against, and we have been struggling with that for many, many years now, and I think we might going more to the green button compared to the other one. But definitely when starting 20 years ago, it was about how can you do that? That must be unethical. But now we're in a position where different institutes around the world from different countries are recommending bariatric surgery to be considered. And American Academy of Pediatrics are advocating for a more aggressive treatment strategy from 13 years of age. Maybe not always surgery in the first, but you should be treating obesity much earlier. And from the Swedish side, we have a new national guidelines from the last year. And that took into account the studies we have done and lowered the age limit to consider bariatric surgery to be 15 years and a BMI over 35. What are the evidences underpinning that we could have guidelines supporting bariatric surgery? There are 3 randomized controlled trials. Actually, one of them was quite long ago from Australia that involved band, and we have only seen 2-year data in press. Netherlands had a banding study, 1-year outcome, and we have 2-year outcomes in AMOS 2 in the randomized trial I will show you. I will show you 5-year data from that. And please, can I say to you, so I remember that if you can, please don't use cameras because it's unpublished data, and that would be helpful if you don't do that when you have results coming. But there is also, as Tom has shown, several prospective controlled studies, very meticulously controlled studies like the Teen-LABS study, and we have the AMOS study. Come back to that in Saudi Arabia, and there are others around the world. When we are considering a procedure for adolescents, I think this is how we all think about this, that there should be a sound balance between efficacy and risk. This is what bariatric and metabolic surgery is about somehow, to find this balance, fine balance. I think also that we need to step away from thinking about restriction and malabsorption. We need to come into the field of thinking that it's about changing signals from the gut to the brain and the rest of the body. And also we need to take into account that there should be no experiment in adolescence. The younger you are, you test first in adults before getting to adolescents or kids. So this is another perspective that we have to take into account, that whatever you do, this is going to be there in some form for 70, 80 years in an adolescent. So that's quite a perspective that is quite sometimes when you think about it. So that's interesting that but that's also probably so that they are more similar than dissimilar, those operations, because they are playing on the same signals from the gut to the brain. And from the Swedish side, we have felt very confident in using Roux-en-Y bypass, and Tom and Group, as you know, has using more sleeve gastrectomy, or at least recently. Those 2 studies I'm going to present from, the recent data, the unpublished data, are firstly AMOS, the first one, which was included in 2006 to 2009. It's a prospective control study, 81 adolescents, 81 controls identified in a registry, and 81 adult controls. Age under 18 and BMI, pubertal stage over 3, and only gastric bypass, 5-year data is published. AMOS 2 is the randomized trial, which was included between 2014 and 2017, 50 patients, 25 in each arm, randomized, 13 to 16 years of age. So we stressed it a little bit going down in age. Was it feasible to operate a bit earlier compared to closer to 18? We included pubertal stage 3 tannery in this, and mainly gastric bypass, and we have published 2-year data. I will show you primary outcome, I will show you secondary efficacy outcome, and what is also very important, as Tom also showed, that we show the secondary safety outcomes. And that is probably more important in adolescents compared to adults, even though it should be done there also. So firstly, AMOS 10 years data. Not published yet, but you can see, I don't know whether we can use that one. No, we can't. But anyway, you can see that it's a little bit hard to read, but the red one are the controls, and quite many of them had surgery over time. up until 10 years. And then you have the blue one and the green one up to 5 years, and that is adolescents and adults, 35 to 45 years of age, and they are matched to adolescents. So what you can see is exactly as Tom showed, that we have the same weight loss and body weight, BMI loss and body weight losses. If we look at AMOS 2, this is a 5-year follow-up where we having per protocol analysis. So we don't include them who had been crossing over. So there is not so many in the control group here, but you can see that there is about a 30% weight loss in the MBS group. But if you look at the intention to treat and take along those who are crossing over from being a control group to being to have surgery over time, you can see this, and the curves are approaching there. Because actually 18 out of 25 of those randomized to intensive non-surgical intervention. Unfortunately, at 2014 and 17, you know that there were no medications around to be used for adolescents. But over 5 years, 18 out of 25 underwent surgery. So how does this compare to, many of you know that this is a SOS trial, which has been used for so long time. The blue one is the control group, and you have the other one, the green one, is the gastric bypass over time. And this is AMOS 1, AMOS the first study, and AMOS 2 for controls. And I want to just stress that this is what differing compared to SOS, that adolescents don't stay still in their BMI. They increase over time, and we have a 10% weight loss over the 5 years. While if we look at the gastric bypass outcome in adolescents compared to adults, it's almost superimposed to the SOS curve. So we can conclude that from body weight BMI perspective, there are similar weight outcomes in adolescents and in adults. We had the same experience as the Teen-LABS group, that there were somewhat greater variability among weight loss outcomes among adolescents. We also have, we and others have shown that behavioral factors does not predict weight outcomes. And however, if you lose more weight, you have a better quality of life. Secondary efficacy outcome, and I will try to do this a little bit quicker, just to show that what we really want to do is to make them healthier. And sorry again for being a little bit small in the text, but you have all the risk factors: waist circumference, systolic, diastolic, blood pressure, HbA1c, LDL cholesterol, HDL cholesterol. They're going all the right way. We didn't have so many controls after 10 years that I'm showing them here. So it's more prospective cohort of those 81 being operated. In AMOS 2, the randomized trial, this is what we see, that glucose was pretty good in both groups over time. Insulin is the one, it takes more insulin to keep the glucose in the control group. And HDL, LDL, CRP, they were at the low level of CRP. Otherwise, in the first AMOS study, we saw a drop from 8 to 2 in CRP. There was a little bit of a difference in hemoglobin. If we're looking at secondary outcomes, efficacy outcomes for quality of life, this is the AMOS study, and I will actually jump to quality of life in AMOS 2, 5 years. So what you see in the left is the baseline quality of life in those undergoing MBS. And at the right, you see the two curves with the controls not being operated and the operated. And you can see that they had quite good quality of life from the beginning, but if you look at what is improving, that is the physical aspects of quality of life. And this is the conclusion I take from this, that we have broad and sustained improvements in cardiovascular risk factors in adolescents undergoing surgery. And we also have substantial and sustained improvements in physical, especially physical quality of life. Okay, now we're coming to the last part, and which I think is as important as efficacy, that is safety for adolescents. Fortunately, we were able to have much less complications with Roux-en-Y's in the AMOS 2 study compared to the first one. And in AMOS 2, which was later, and we had a little bit of maturity of that technique, we had 4 adverse events over 5 years, and all were mild and without need for treatment, except for one having a cholecystectomy. Sorry, I left that out. Safety outcome is also about height and puberty. Does it affect adolescents negatively to undergo bariatric surgery? And these are studies from others, and they show that final height is not affected. They grow as much, and there seems to be some data supporting that you actually have a more normal height growth over time after surgery. And also that there is no meaning of saying that they should have their full pubertal development when having surgery. On the opposite, it seems that weight loss appears to be beneficial for pubertal development. Again now, coming from AMOS 2 it is. Yeah, it is, because it's randomized. Sorry, it says AMOS, but it's AMOS 2, the randomized study from Nutritional point. And here you can see when we were more active compared to the first study, we can see that hemoglobin, D vitamin, ferritin, and iron is not that dissimilar among those having non-surgical treatment compared to those undergoing surgery. And that was probably due to having a more aware strategy of supporting the supplementation over time. Tom showed you some data, and I show you here about 5-year data, and that is also AMOS 2, sorry for this, that they have a growth in bone mineral content in the surgical group, but that's per kilogram. And the difference is that you see upper right that bone mineral density is the one decreasing. They are coming from a quite high level in bone mineral density, but they are approaching a normal range. And some of them are at the lower range of this. And you can see also here the lumbar and the hip. There is a significant difference between those undergoing surgery compared to controls. And this is something we need to look over even longer time. If we look at gastrointestinal symptoms, are they unable to live a normal life? No, there is no major difference between those having surgery and not having surgery. And this is a message I think we should bring out. If you have problems with eating after a gastric bypass, that's not normal. And I think the same goes with a sleeve gastrectomy. Nurses were asking whether anybody regretted to be joining the study, and the surgical group, fortunately, none were regretting. And in non-surgical group, 2 of them, but they were more helpless for not losing weight. So I'm wrapping up with saying, what lessons have we learned from the AMOS to tell the adolescents when they come into this? We know that they can most likely achieve a good weight loss. That's expected. It's not like random if they lose weight or not. They will most likely lose a lot of weight. However, weight loss makes you healthier and more functional, but it's not necessarily making you happy. And that is a very strong message now, and I think it's been so important for us to realizing that if you have problems with mental health issues before surgery, that is something that don't goes away with a kilogram. We want to follow you for many years after MBS. It's not just throwing in an operation. We want to see you for at least 5 years from the younger side, and then we have to have some kind of transition. You need to take supplements for a long time, for lifelong, and please contact us if you're not feeling well. If you need help, contact us. The multidisciplinary team consists, of course, of pediatricians, pediatric nurse, psychologist is very central in this, and surgeon also, and dietitian, of course. So this is the team, and I think what's been in other sessions here, that at least one of you in the team should know the patients very well and be the you're sensing what is going on, and you can activate the other ones. And lastly, mind the gap between the child and adult clinics, because they can disappear in follow-up when they're leaving the pediatric clinics. There are some articles to be read if you want to have more of this. And of course, this is a team effort for so many helping to bring this to data. Thank you very much again for having the opportunity.
And next we'll have Justin Ryder, who is not a surgeon, but a obesity researcher extraordinaire, and has been working with me in Teen-LABS research for about half dozen years or so. And is going to talk to us about maybe another group that should be compared, but I'll tease it with that.
Great, thanks Tom, and thanks everybody for skipping the bar over there to be here. So I'm going to talk about special topics, the intersection of surgery and pharma, try to bring it together, and I'm going to bring it back to some examples from Teen-LABS and AMOS to help me. Here are my disclosures, and I'd like to thank my funders. So I've broken my talk up into 4 hot topics or 4 important questions. And we're going to start with the first one is, who's likely to respond to obesity treatment and which one? So I'd like to remind everybody that obesity treatment in pediatrics is circular. We have behavioral treatment. We have now pharmacotherapy, as well as surgical options, as we just discussed with Teen-LABS and AMOS. And the American Academy of Pediatrics in 2023 published new guidelines around the use of all 3 of these treatment options. Intensive behavioral and lifestyle treatment is suggested to be greater than 26 contact hours over 3 to 12 months, which is very, very difficult. Pharmacotherapy is recommended per FDA label. Right now, we only have medications FDA approved for individuals 12 and up, but I do suspect in the next couple of years we will have a lower approval for 6 to 12-year-olds. And then bariatric surgery is suggested by the AAP to be 13 and up with a BMI of 1.2 times the 95th percentile. But I think it's important for everybody to know and think about this as a non-linear continuum of care. You don't need to start lifestyle, then go to meds, then go to surgery. Meet the patient where they're at, evaluate their comorbidities, and then decide what's the best treatment option for your patient. And one of the reasons for that is that the heterogeneity of treatment response is significant to all treatments. This is pooled data from Tom, my colleague Erin Kelly at the University of Minnesota, and my colleague Gabe Scheibe at Arizona State. We took all of our data. This is all baseline to 1 year of the 3 main treatment options. And this is early stage pharmacotherapy, so phentermine, topiramate, and exenatide, so it's not the newer GLP-1 receptor agonist. But you can see that there's substantial heterogeneity in all treatment types, and you can create this waterfall plot with everything, and you'll see more of these to come. But even with surgery, this is all Roux-en-Y gastric bypass, all the same surgeon. He's sitting over there. And even with that controlled atmosphere, your heterogeneity is 50% weight loss to 10% weight loss with surgery. And so we're going to have and need additional treatment for some individuals. And this is where I think we need pharmacotherapy to be with the newer agents that are coming down the pipeline in order for it to be a successful additive treatment option. And even, I'm going to dive into this a little bit further with some data from pharmacotherapy. So this is the liraglutide pivotal trial. Aaron Kelly, my colleague in University of Minnesota, published these data. And you can see it causes about 5% weight loss in adolescents with severe obesity. But one of the problems is that obesity in pediatrics is a lifelong disease. And when you remove the treatment, so this was FDA mandated for a 26-week removal of the treatment, these adolescents, almost all of them went back up to their starting BMI on average. And so obesity is going to require lifelong treatment. Doesn't mean that people can't respond, though, to other treatments. And so again, these waterfall plots indicative of pharmacotherapy heterogeneity. On the left side, you see with liraglutide, we have individuals who don't respond to the medication. And you might say, well, maybe they weren't taking it, but in this study, they actually measured drug levels throughout the trial. So they knew that these individuals were adherent to the medication, and they still gained weight. But then on the flip side, in the placebo group, that got very modest lifestyle, probably akin to 4 contact hours over the course of a year, we still have some super responders, some kids that responded to this treatment option. And this is adolescent data, again, 12 to 17-year-olds with semaglutide, and you see the same thing, where on the panel A, we have when we remove the treatment, their BMIs go up, and they go up rapidly. But we also have a good amount of responders. So 37%, or a third of the individuals, lost 20% of their BMI, but it's still not probably sufficient to treat the masses. And still within the pharmacotherapy group, again, they measured drug levels in this, we still have some people that are non-responsive to even medications and pharmacotherapy. And again, people in the placebo group that still do quite well. So the question is who's likely to respond to obesity treatment and which one? The answer is we have no idea. But the data would suggest that you need to try different treatment options and see which works best for each patient. Okay, so when do we add medications to surgery? I think this is going to be the next step in our question. We know surgery works. AMOS demonstrated it. AMOS 2 demonstrated it, Teen-LABS demonstrated it. We know that it works, but we know that for some people, they're going to need additional treatment. When do we add those medications? So this is another way of looking at our 10-year outcomes from Teen-LABS that we published last year in New England Journal that Tom showed. And you can see in the gray bar is baseline BMI. This is distribution by every 5 BMI units. And then at 10 years, you can see there's a flattening of the curve where we have 17% of our cohort that no longer has obesity, but we still have a little over 70% of the cohort still has class 2 obesity at 10 years, and 52%, so half of the cohort still has class 3 obesity at 10 years. And so this is really the group where pharmacotherapy is going to be necessary. We had great outcomes with Teen-LABS, 20% weight loss at 10 years, but still we have lots of individuals with severe obesity. And so I did the math, and we have 82% of the cohort at 10 years who still qualified for OMMs or AOMs, however you want to call them. So 10 years is not the optimal time to intervene. So this is another way of looking at the same heterogeneity data. This is called latent class analysis. It's not quartiles, but we basically put into an algorithm a way of identifying phenotypic groups of individuals, where we had in black on the bottom our super responders who at 10 years had a BMI reduction of 43%, which is remarkable. And in yellow, still a group of really fantastic responders, a third of the cohort. who had a mean BMI reduction of 27% at 10 years. And then in blue and red, we have our, I wouldn't call them non-responders, I would call them individuals that they failed on that treatment option or need additional treatment to be placed upon them. And we really don't know what's going on in this group, and so we've tried a lot to identify, what separates somebody in the red group versus the black group. And the only thing that really pans out from a demographic or clinical perspective is what happens to them at 6 months. So at 6 months, we've identified that if you don't have a BMI of 24% reduction or more, you're more likely to be in the blue group or the red group. And so that's probably the optimal time, at least from these data. Maybe it's at 3 months, but we just didn't measure it at 3 months. But at least at 6 months, if they haven't probably hit 24% BMI reduction, you're going to need to hit them with another tool, and that's probably going to be pharmacotherapy. So the holy grail, as far as I think about it, is if you're a clinician, when you have a patient in front of you, could you identify before they even had surgery or before you put them on a medication, can you tell who's going to respond or not? Can you tell who's going to be in the black and gold or who's going to be in the blue or the red? And so we've done some work using metabolomics in Teen-LABS, and we've identified numerous baseline metabolites that are associated with long-term weight loss maintenance. So we collapsed the groups, we put the black and the gold, the responder groups together, and we collapsed the non-responders together, the red and the blue group. And we can take those metabolites and put them into an algorithm to help us predict before surgery even happens who's going to be our responders. And what we found is that our metabolite model alone can predict with about 85%, so the AUC is 0.852, about 85% predictability of who's going to respond to surgery or not, be in that responder group, that black and gold group, or the blue and red group. And if we add demographics to it, it actually doesn't improve our model. So it doesn't matter really what your sex, age, BMI, where you live, race, any of those characteristics, it didn't matter. And actually, if you just look at the demographic characteristics, it's about a 56% predictability. So it's a little bit better than a coin flip. So I do think that we will get to a world where we do have some precision medicine approaches where we can identify who's going to be our people that are going to respond well, but also maybe they have surgery and you say, your metabolic profile suggests that you're also going to need another medication on top of that surgery. Just doing Roux-en-Y gastric bypass is not going to be enough for you. Okay. So then the question becomes, what medications do we start with as our add-on? And this is a really difficult question because in pediatrics, we only have a couple of medications that are currently FDA approved. There's going to be more in the pipeline. So I'm going to think about this from a pipeline perspective, not necessarily what we have today. And I'm going to go back to AMOS. So Torsten was very generous and allowed Andy Beamish, who's a surgeon in Wales, and myself to work on some AMOS data to look at fat mass and fat-free mass changes. And why is this important? Adolescents are growing. So this is data from Norway. That's a longitudinal study over many, many years, and you can see both males and females increase their fat mass and fat-free mass, with males increasing fat-free mass to a greater extent than females once they hit puberty. Well, what happens after bariatric surgery? These are DEXA data, so it's about as good as that we can get. And what we found is that both males and females have a nice, steep, linear decline in fat mass after bariatric surgery, and they maintain it to similar degrees out to 5 years. And the sample size here is 50. But with lean mass or fat-free mass, it's a slightly different story. Males start higher and also lose proportionately less fat-free mass than females. So one of our thoughts was maybe the difference in lean body mass changes actually predicts weight regain. We debunked that hypothesis in this paper. You can go read it, so that was wrong. We thought that changes in visceral fat, which were measured in this study, might be predictive of metabolic adaptations. That wasn't right either. But I do think you need to take this into consideration that there is going to be some biological differences between males and females, especially as it relates to muscle mass. And so when we think about this and what pharma do we add on, I think we've got really 3 categories of medications that we can think about that are either on the market now or going to be on the market in the very near future. So the first being, GLP-1s, the inclusion of GIPs and glucagon, and we'll talk about that one first. And I think it's everybody's assumption that this is going to be the best additive medication. I actually am not convinced of that because of what bariatric surgery does to all 3 of these hormones, GLP-1, GIP, and glucagon. So this is a study in adults published a while ago. There's been some other studies. Actually, Torsten in 2007 published a paper on this very similar thing. Pretty consistently, after bariatric surgery, if we start up here at the top, GLP-1 levels rise exponentially. And this is 3-month data. And this is from mixed meal tolerance tests that stimulate all 3 of these hormones from carbohydrate ingestion. And you see that that GLP-1 gets a super physiological increase following bariatric surgery. So adding a GLP-1 receptor agonist in an environment that is already rich with increases in GLP-1, I don't know if that necessarily makes sense. Nobody's studied it from this level, so if you're an early career scientist, this would be a great study to do, to look at the additive effect. Are we actually going to get an increase in GLP-1 levels to promote additional satiety by adding semaglutide or tirzepatide? I'm not sure. A small increase in GIP and small increases in glucagon, and this is what all of the next stage pharmacotherapies are going to do. Surgery already does this, and it tends to subside after about a year or 2, but at least in the first year, these levels still remain very, very high. So I don't know if you're going to get so much of an added benefit by adding a GLP-1 or a multi-agonist, but again, that study needs to be done. Another option is Qsymia, which is the combination of phentermine and topiramate. And Qsymia acts on the brain in different pathways than GLP-1 receptor agonists do. And I think also importantly, when we go back to our muscle mass conversation, one of the things that phentermine does is it increases energy expenditure to a small degree, about 50 kcals per day. And so if we think about we're reducing lean body mass, perhaps something that increases energy expenditure might be a way of inducing further weight loss in the post-bariatric setting in non-responders. And then there's a pipeline medication, just finished phase 2 trials. This was presented at Diabetes Week in June of this year. The medication is called begrumumab. It is a monoclonal antibody that really works on muscle. So it blocks a myostatin within skeletal muscle called activin type 2. And so if we look at the bars here on the left side, begrumumab alone causes weight loss, but without any change or reduction in lean body mass. So they lose weight, and it is all fat, 100%. And when you combine begrumumab with a GLP-1 receptor agonist, it actually spares some of the fat mass that's lost. So the individuals that were on semaglutide plus begrumumab lost 90% of their weight from fat mass, not fat-free mass. And so potentially, if we're seeing this decline and decrement in lean body mass, this might be a nice additive medication on top of bariatric surgery to get long-term benefit. All right, I'm going to try to speed up with this last one, but it's more of a provocative question. Are GLP-1s going to put those of you who are surgeons out of business? And my answer to this is no. And I really think that the only comparable example that we really have is what happened with the advent of ACE inhibitors and statins on cardiovascular disease risk. Did those 2 drugs that were really transformative in the marketplace, just like GLP-1 receptor agonists have been and will be, did it put surgeons out of business? And the answer is no. We still have people that have cardiovascular events. They still need cardiovascular and cardiothoracic surgeons. And GLP-1s are going to have their place in care, but they are not going to put bariatric surgery out of business. And one of the real challenges is in pediatrics, we can't treat everybody who needs to have surgery with meds either. So 1 in 23 adolescents in the US qualify for bariatric surgery. That's 1.8 million adolescents right now currently in the US. And the prescription rates of GLP-1s, even as they got approved, is only about 4,000 to 5,000 per month. So we have a long way to go to get a number of medications out there. And one of the biggest barriers and challenges with that is there's not really good coverage right now in the United States. If you have type 2 diabetes, GLP-1s are covered ubiquitously across all states in the United States. But if you have obesity, most of them are not covered. Only right now 15 states in the US cover GLP-1 receptor agonists. Why is this? It's stigma and bias towards persons with obesity. This is both representative of adults and adolescents. And so I do think, the pipeline is vast. There's 8 medications that are currently FDA approved. There's about 100 in the pipeline, and companies are spending lots of money. I think they're going to be complementary to what bariatric surgery offers. And really, I think the take-home for me is that you don't see these results with medications. These are 2 surgeries Tom performed last year, both sleeve gastrectomies in adolescents with severe obesity. This young man on the left, no longer has obesity at 1 year with a 41% BMI reduction. And this individual is actually normal weight 1 year after bariatric surgery after having severe obesity. You're not going to get that with medications. It's just not going to happen. And as Tom alluded to earlier, and I won't replicate, we have better remission of type 2 diabetes. Our 10-year data is very, very promising, showing full remission at 10 years of type 2 diabetes at 73%. And as he alluded to, it's about 18% in adults. You're not going to see that with medications. And then, so where do I think medications have their place, and why I think that bariatric surgeons are not going to be put out of business is this. So we have on the bottom here these individuals that didn't respond to semaglutide. Those are now our perfect candidates for bariatric surgery. If you don't respond to semaglutide or tirzepatide, you need surgery. But then again, the individuals who regain weight, that is where also bariatric surgery, I think, is going to come into play. And I think there's going to be a lot more business to come. So some take-home points. That obesity is, a highly heterogeneous disease, and we need to really identify some of the mechanisms and predictors of response. And I think it's rapidly evolving, but if we should think of everything as complementary. How do we add things together to get the best outcome? Not surgery versus meds versus lifestyle, but how do we bring all 3 of those together? And that's my talk. And thanks.
Thanks again. We are right on time, and we're going to be taking questions at the end of the session. Next, I'd like to introduce Dr. David Sarwer, whom I've known for many, many years with his prior work as a clinical psychologist and a psychologic behavioral researcher as well. He's currently, however, Senior Associate Dean for Research and Director of the Center for Obesity Research at Temple University, where he's a full professor. Potential spam. And has been funded for by the NIH for studies of behavioral outcomes after bariatric surgery, adult and adolescent bariatric surgery. So again, I know that he regrets not being here in person, but he was kind enough to share his expertise with us with a pre-recorded video, and I'll ask for the video to be played at this point.
Hello, everybody. I'm Dr. David Sarwer. I'm the Senior Associate Dean for Research and Strategic Partnerships, as well as the Director for the Center for Obesity Research and Education at the College of Public Health at Temple University in the United States. And I'm very sorry that I'm not able to be in person with all of you today during this great session and the entire meeting. My wife underwent a significant surgical procedure last week, and I needed to be at home to help her during her recovery. The great news is she's doing fantastic, and that I'm able to have a little bit of time to share my content with all of you as part of this outstanding session on adolescent, metabolic, and bariatric surgery. And I'm going to really focus my remarks on the psychosocial and behavioral aspects of surgery, both before and after procedures. And hopefully I'll give you all a sense of why I think it's really important that the entire MBS team really approach these things from a very thoughtful perspective as we evaluate adolescents who are interested in these procedures and we help maximize their lifelong outcomes. One of the areas where I do a lot of my work is focused on what I like to refer to as the psychosocial burden of obesity. That with the growth of obesity around the world, both in adults and adolescents, and all the focus on the efficacy and safety of treatments like MBS and pharmacotherapy, I do think it's really important that we remember that our patients often present to us with a significant psychosocial load on their shoulders. That in a society, in a world that values leanness as a marker of physical beauty and attractiveness, individuals with more severe forms of obesity can experience a lot of psychosocial challenges as a result. And the ones that I've highlighted in red here are ones where we're actually going to focus some of our attention today. I think there's some really important issues around sexuality and sexual behavior in teens who undergo MBS. Many of these findings coming from Dr. Inge's Teen-LABS study in the United States. We also know that there are issues around substance misuse, both alcohol and other substances that we need to be mindful of. And then some important work that's come out of Dr. Ahlberg's team in Sweden over the last couple of years, focusing on the fact that there are some adolescents who are struggling with issues around cognitive impairment, decision-making, and risk-taking behaviors, which I think we need to be mindful of. And then finally, the issue of bias and stigmatization. And the thing that I always try to remind myself is that for adolescents who are candidates for metabolic and bariatric surgery, they in some situations are probably the largest and heaviest student in their school setting. And as a result, they may be noticed by everybody and known to everybody, but not for reasons that any of us would desire for somebody that we love. And that, again, must be a significant psychosocial burden for many of these adolescents. And so as a result, over the last 10 to 15 years, we've had organizations from around the world, including IFSO, who have issued a number of position statements underlying the importance of evaluating the psychosocial status and functioning of adults and adolescents who present for metabolic and bariatric surgery. And that these evaluations should be considered in all patients and then absolutely are recommended for those with a known or suspected psychiatric illness. And we know from other areas of this literature that we don't have time to review today that that's now describing the majority of patients. So more than 50% of patients come to metabolic and bariatric surgery with a psychiatric condition in either currently or in their past. And that means the majority are likely should experience and benefit these evaluations. And I think for adolescents in particular, again highlighted in red at the bottom, these issues need to be considered from both a developmental perspective as well as a family-based perspective. And we're going to get into, over the next couple slides, a little bit more about what I mean by that. But unlike an adult patient where the evaluation is often so very much focused on the experience of the individual, it's really important that we consider the development of not only the adolescent in front of us, but the family dynamics that impact the decision whether or not to go forward with surgery. So the goals of the evaluation are to identify that those significant psychological issues and potential psychiatric contraindications. It also provides patients with an opportunity to understand the environmental and behavior contributors to the development of obesity. And also mental health professionals who do these evaluations, much like dietitians and nurses, provide some really important psychoeducation on the dietary and behavioral requirements after the procedure. And this is really important for adolescents because unlike a lot of adults who are what I like to call dieting veterans, a lot of adolescents with extreme obesity do not have years of experience trying to lose weight through more conservative means. So they may not have the fund of knowledge and experience understanding nutrition and eating behaviors and reading food labels that many adults have. I think it's also really important to note that this evaluation is an assessment of risk of a suboptimal outcome. It does not predict outcome. And much like we ask patients to undergo a variety of medical clearances before surgery, those consultants are asked to evaluate the risk of the procedure. They're not asked to give the surgeon a crystal ball and say, here's what I predict will happen post-operatively. What are the major elements of these evaluations? Well, again, they're listed here, and the ones highlighted in red I think are particularly worthy of our attention as we think about adolescence. So the history of psychopathology, and back to that developmental consideration I mentioned a few moments ago. Most forms of severe psychopathology begin to show themselves and present as symptoms in the late teenage and early adult years. And so it may be that patients who are going to in the future have challenges with depression or substances or severe anxiety are showing some of the early symptoms of those conditions as they're presenting for surgery, but not perhaps meeting the full diagnostic criteria. So it's really important for those mental health professionals to drill down and assess those symptoms very carefully. Family and social support. Are the guardians and the parents and other members of the family and those living in the home supportive of this? Are they going to be willing to make dietary and behavioral changes in the household that will support the success of the adolescent undergoing surgery? And as I mentioned early on, some of the really interesting work coming out of Dr. Olberg's team in Sweden, along with Dr. Jarholm, looking at cognitive functioning in adolescents, as well as their decision-making capacity and risk-taking behaviors. And what this early signal seems to suggest, at least to me, is that some teenagers are challenged by these issues. And we need to be mindful of the fact that as we're delivering medical information to them, we're providing them with behavioral instruction, their cognitive functioning and their decision-making capacity may not be where we'd like it to be ideally. And thus, we need to maybe repeat things more often, deliver information repeatedly in multimodal forms. So just saying something to somebody and also giving them something in writing can be really, really important. And I think we're going to learn more about this important issue in the years to come. In the last few years, along with my colleagues at Temple University, we've actually started doing a little bit more work on the intersection of what are known as adverse childhood experiences, ACEs, and childhood and adult obesity, and the contributions that those unfortunate experiences, physical abuse, sexual abuse, emotional abuse, and other things that can occur in the home can have on healthy development and weight development across the lifespan. So this review paper was published in Obesity Reviews in 2021. I am incredibly proud to say it has already been cited over 200 times. My three co-authors on this paper are early career researchers in the college who this is a large focus of their work, and I was thrilled to have the opportunity to join them and watch them actually build on this success with some of their subsequent work. Coming out of the Teen-LABS study that Dr. Inge led, there was a sub-study called Teen-VIEW led by Margaret Zeller that actually will provide us with a lot of really important information I'm going to share with you over the next few minutes. And one of the things that Dr. Zeller focused on in her work, I apologize for that, was looking at child maltreatment, which is what we now call ACEs, or adverse childhood experiences. And in that Teen-LABS study, which were 5 clinical sites across the United States, who recruited over approximately 140 teens undergoing surgery and 83 adolescents not undergoing surgery, the prevalence of childhood maltreatment was similar to rates in the general population in the United States. So about 30% of girls, about 10% of boys reported that history in their past. But what we did see in those patients presenting for surgery is a relationship with greater psychopathology, substance use, and family dysfunction, as well as lower quality of life. All things that, again, underscore the importance of assessing and monitoring those issues as adolescents present for surgery. So what are the mental health contraindications to metabolic and bariatric surgery? Well, they're largely the same for adults and for adolescents. Severe uncontrolled psychopathology, so someone who has severe untreated depression, has a more significant mental health issue like schizophrenia, those individuals can have surgery at some point in time in the future, but those mental health disorders need to be well controlled and managed by other providers. Active substance misuse, as well as a profound lack of knowledge or understanding of the behavioral and dietary requirements of surgery. And this, I think, getting back to some of that work coming out of Sweden, we really need to be thoughtful of, do the adolescents who are presenting have the cognitive horsepower and the abilities to really understand what they're going to have to do post-operatively in order to be successful. Now let's switch over and focus in the time that I have left on some post-operative issues. The reality is the vast majority of adults and adolescents experience tremendous benefits from MBS. They see substantial and durable weight losses, an improvement or resolution in many weight-related health problems, as well as a significant improvement in their psychosocial status. So if you'd like that phrase psychosocial burden, by losing that significant amount of weight and getting healthier, a lot of that burden seems to be lifted, which I think is a fantastic thing. Unfortunately, there are about 10 to 20% of our adolescents who seem to struggle with mental health and behavioral issues postoperatively. And in a study that was published earlier this year, a qualitative investigation of 18 adolescents who had undergone metabolic and bariatric surgery, we see and hear in their own voices the importance of some of that postoperative care. So what were they telling the investigators in this study? Weight loss was pivotal, improving daily life to enhance physical and mental health, but they also recognized and expressed a need for enhanced access to primary and healthcare specialists who knew about metabolic and bariatric surgery and what happens postoperatively. They also recognized the need to have a mental health provider available to them and to have the psychosocial support available to them to make positive changes. So what are some of the issues that we worry about in that 10 to 20%? These are really the three most common and really where I'm going to focus my remarks in the time that I have left. So we're going to talk a little bit about changes in sexual behavior, the return of pre-existing psychopathology, as well as postoperative weight regain. Again, going back to Dr. Zeller's work from TeenView, which was an ancillary study to Teen-LABS, she did a deep dive on looking at changes in sexual behavior as those adolescents got older. So we could see, again, we're comparing adolescents who underwent MBS right around the age of 17 to adolescents who also had more severe forms of obesity but didn't have surgery. They were about a year younger. And in the 4 years that they were followed, most reported that they had their first experience with sexual intercourse, with greater increases in behaviors conferring a risk for sexually transmitted infections, particularly in girls who had undergone MBS. Now, while they were engaging in some of these riskier behaviors, the rate of sexually transmitted infections was in fact not different between the two groups, but the rates of pregnancies were. So what we see is that of those who underwent MBS and were more likely to report a pregnancy, we see almost a 3 times greater rate of pregnancy in those who underwent surgery. And we also see 15 live births in the surgical group versus 1 in the non-surgical group, with 50% of those babies born to what are referred to as teen mothers. And I think this really speaks to the need to provide another layer of education and instruction to these adolescent girls about issues around sexual behavior, risk of sexually transmitted infections, and also risks of early pregnancy. As I said, we've been doing a lot of work in Philadelphia looking at ACEs and relationships to metabolic and bariatric surgery, and a number of studies have investigated this relationship, but the results are largely inconclusive. While some studies have suggested that ACEs are related to postoperative weight loss, others have not found that relationship. But many studies have found that patients with a history of ACEs do experience more emotional and psychosocial turbulence during the postoperative period. And they also have worse biomarkers for things like cardiovascular disease, as well as a higher BMI, suggesting that that history of an ACEs in their background may be disrupting their ability to engage in the recommended behaviors to promote that most positive postoperative outcome. What about issues around alcohol use? Well, Dr. Wendy King in Pittsburgh did some seminal work in a nationwide study in the United States that showed that the further people get out from their metabolic and bariatric surgery date, the greater the increase in their rate of alcohol use disorders. So while she found no difference in the rate of alcohol use disorders in year 1 postoperatively, but it did increase by postoperative year 2. And by postoperative year 5, 1 in 5, or 20% of these adults, met diagnostic criteria for an alcohol use disorder, meaning they were overusing alcohol, which can not only contribute to weight regain, but can be signs of mental health issues as well. And while this work is in adults, I think it's really important that we be mindful of it and realize that we may over time see very similar patterns of results in adolescents. We do see in some more recent work that there are greater reports of substance use and alcohol misuse in adolescents who have undergone bariatric surgery. So we could see that being a woman, pre-operative lower body mass index and pre-surgery substance use were independently associated with the increased risk of hazardous drinking post-operatively. And that pre-operative mental health treatment also was associated with increased use of new onset substance use post-operatively. So, and we can see, again, that things like greater percent weight loss, mental health treatment, and alcohol use were associated with a greater risk of post-operative substance misuse. And I think this really underscores the role, again, of the entire team in assessing and being prepared to manage patients during the post-operative course. In the United States, issues around cannabis use are very convoluted. While there is a federal law around that it needs to be used for medical purposes, there are other laws vary from state to state around recreational use. So in one state, cannabis may be very, very available. In the adjacent state to it, it may not be available very much at all. But we do know that in general, regular use of cannabis in all its forms is associated with a range of health concerns, which is really at the odds of what we're trying to accomplish with MBS. Again, the state laws cloud these issues, but we recommend, both in a paper written a decade ago and a more recent paper from ASMBS earlier this year, that patients are regularly questioned and screened about their use of cannabis to make sure that they are not misusing these substances. We also know, unfortunately, that suicidal thoughts, behaviors, and actually committed suicides are relatively common, although infrequent, in individuals who undergo MBS. And this is true for adolescents as well. That rates of suicidal thoughts and behaviors are low and similar to national base rates, but we do know that the adolescents who are reporting this also are reporting psychopathology, victimization, emotional dysregulation, and substance misuse. So again, we're beginning to see this cluster of how a lot of what we're talking about today all kind of comes together in an individual patient who maybe warrants more of our clinical attention. So what would I recommend if we're seeing adolescents who are challenged by these issues post-operatively? It really requires and warrants intervention by a mental health professional. If you had a mental health professional evaluate that adolescent prior to surgery, that's a great place to start. But if that professional is not available or that evaluation was not completed, I strongly recommend that all teams have a few mental health professionals available to them where they can make referrals when necessary. And with this in mind, my colleagues and I at Temple, along with my colleague and friend Dr. Leslie Heinberg at the Cleveland Clinic, recently wrote a paper about bringing the principles of what is known as trauma-informed care to metabolic and bariatric surgery, to recognize that many of our patients have a history of trauma in their past, that some of the interactions that we have with them in the process of going through surgery can trigger and re-energize some of those experiences that can cause some of that emotional and behavioral dysregulation that really can warrant more attention and care by the team. And in the last few minutes that I have, I just want to talk about weight regain. This is a slide that comes from Dr. Ryder recently in long-term improvements over metabolic bariatric surgery. And up at the top here, I really want you to pay attention to how both groups, the sleeve and the gastric bypass group, are regaining weight over time. We know that weight regain is common, it's predictable. I focus a lot of my attention on people who are regaining more weight than we would expect. So those who are above these lines and within these bands. What are the reasons for this? It's multifactorial. That can be physiological adaptation. It can be issues around depression and binge eating. It can be disordered eating, and also poor adherence to the post-operative diet. And there have been a number of studies that have been done recently looking at these issues, knowing that teens do, in general, report improvements in their diets over time, but that in some instances, problematic eating behaviors and eating disorder symptoms do reoccur. And in perhaps the most recent study of this group, greater self-reported disordered eating was associated with a lower percent weight loss 6 years after surgery and a greater percent weight gain for those who did not undergo surgery. Again, repeating that signal that we all know too well, that disordered eating and a kind of disorganized diet and eating behaviors contributes to weight gain over time. So when people are regaining weight, here are some recommended solutions. If it's physiological in nature and there really seems to be no behavioral component, I really think that's where use of the anti-obesity medications or the obesity management medications can be very, very helpful. If it's preoperative psychopathology that's returning, I think that's when getting a mental health professional involved makes a great deal of sense. If it's disordered eating, a mental health professional or a dietitian can play an important role. And if we've got poor adherence to that postoperative diet, again, I think that's an opportunity for the dietitian to reconnect. So in summary, adolescents who present for surgery, just like adults, also often do so with a range of psychosocial and behavioral issues that warrant our attention, both our assessment preoperatively and perhaps our management postoperatively. While a minority experience these suboptimal outcomes, we need to be mindful of things like smaller than expected weight loss or unwanted psychosocial experiences. And that for these adolescents, what that lifelong journey is going to be is a story that's yet to be told. And we have a lot to learn from these early patients who have undergone surgery within the last 10 and 15 years that we can now follow over longer periods of time and be better prepared for the next generation of adolescents. And I do think it's really important that for all of us, while adolescent surgery is still done with some level of infrequency, that we really be prepared to not only carefully assess these patients, but also target and develop longer-term interventions to promote lifelong success. Again, I want to thank you for your time and attention. I apologize I'm not there with you at the meeting. I'm missing my friends in Santiago and in South America more generally. But I hope you have a fantastic meeting. And please do feel free to reach out to me if you have any follow-up questions or things you'd like to discuss. My email's at the bottom of the screen. Thank you all.
All right, well, thank you, David. Thank you, fellow presenters here. And apologies for running over, but as I understand it, the farewell dinner is not for 2 hours. So, hey, why don't we do some question and answers? Anyone have any questions? Torsten, why aren't we operating on BMI 28 diabetics? Individuals with diabetes.
That is a good question. That's true metabolic surgery. We treat diabetes and then we can have some side effect that you have weight loss. That would be interesting. I think what you are aiming at is what I also wanted to bring before we have the question there, that you mentioned, Justin, that you kind of should be quite aggressive of adding on. I am a little bit worried that we are kilogram hunters in the way that we are aiming too low with the weight loss, and that we maybe should be very meticulous before to say what are we going to make better. Yeah. I know that weight counts more for adolescents compared to adults. It's more predictive, but I think maybe how much do we need to lose weight in order to get the benefits?
I'd rather be known as a diabetes hunter.
Yeah, a diabetes hunter.
First question. Thank you.
Yeah, I have a couple questions, but I don't want to monopolize the Q&A, so I'll just stick with my first one. So given that children are inherently high risk for injury, in your research, did you all look at fracture incidence or prevalence?
We did, actually, and we did not see any difference in the rate of fracture, which was pretty low before surgery versus after, but we carefully inventoried before and after.
Okay. And in that, you looked at the general pediatric population versus your study participants?
We actually didn't have, so we did have that control group in the 9-year study, and so they had similar fracture rates historically as our patients did, which would be higher than weight normal controls because there is a higher risk of certain fractures, Colles fractures and so forth, in the folks with obesity.
Right. And then related to that, did you all supplement your patients with calcium and vitamin D?
Absolutely. We did not infuse it, but we did give everyone recommendations for multivitamin, calcium, as well as B12, and we actually did give parenteral B12, in other words, subcutaneous IM B12 shots in the operating room and post-operatively at 6-month intervals.
Okay. And I'm asking because of the decreases in BMD, is there any push for perhaps increasing those supplementations because of the drop?
Yeah, I think, again, it becomes more of a matter of behavioral and compliance, and human beings, be they teenagers or adults, are pretty lousy at being consistently compliant. So I think that we're seeing, and we have measured compliance early on, like in the first 6 months. It tanks, literally tanks in the first 6 months. So I think that we're seeing very, very low supplementation despite our recommendations, and we're seeing them and how they're surviving in the wild, if you will, with their dietary intake of the native nutrients and micronutrients in their diet, sadly.
Could I have a comment on that too?
Yeah, absolutely.
We have some, we have data in adults saying that not one size fits all. that it's probably so that we need to find the group that has the worst outcome in terms of having deficiencies, because there seems also be a group that do very well over time despite not taking any supplements. And somebody we need to be meticulous in chasing of and reinforcing them of doing it.
They're not malabsorptive operations.
No, so so that is important to kind of not one size fits all.
Yeah.
I think that we need to go to.
Interestingly, some of the animal data, too, that we've seen from Randy Seeley suggests that the set point for iron levels in animals, at least, is decreased after bariatric surgery, sleeve gastrectomy in particular. So I think we do beat ourselves up and beat our patients up and think, well, you need to take more for the patients that have these low ferritin levels. And we have some inkling, at least from the animal studies, that the set point may actually be reduced, and hence they're fighting an uphill battle. So it's more about looking at the red cell mass and hemoglobins and realizing that, yeah, there's some anemia, but it really is not transfusible anemia. It is a modest anemia. And any additional questions? Okay, everyone wants to get over to the room with the bar, I guess. All right, thank you so much for your time, gentlemen, audience. I really appreciate it.
Thank you.